We will continue to delve into interoperability for our next panel. But before we get started, there are two things about data and interoperability that I personally love. Data save lives, interoperability save lives. And the reason why I love these two statements is because they put the emphasis on the relationship between interoperability and patient health outcomes. Earlier this year, Infoway published the results of the 2020 National Survey of Canadian Nurses and the results of the 2024 National Survey of Canadian Physicians. And these two surveys revealed that nurses in Canada, they spent 60 minutes looking for information, patient information, outside of their practice setting. And our physicians, they spent 80 minutes, 80, searching for information outside of their practice, patient information. And these two numbers, ladies and gentlemen, they underscore the need for a more interoperable healthcare system in Canada, right? Now, for our next panel, please join me in welcoming to the stage our moderator, Dr. Ed Brown, and the panelists, Dr. Kathleen Ross, Dr. Michael Anderson, Dr. Rashad Bayat, Elizabeth Tuller, and Terry Price. Together, they will provide a first look at the highly anticipated Digital Health Interoperability Task Force recommendation report. And it is going to be an opportunity to explore the transformative potential of these recommendations, offering real-world insights and actionable strategies to improve care delivery for both physicians and patients. Welcome.
So thanks, Waldo, and good afternoon, everybody. This has been a really interesting and exciting day. Lots of enthusiasm out there, great comments, great guests. It was interesting to see Health Canada come. We had the minister, the deputy minister, and the ADM, right? In Canada, we call that a hat trick. And we had them all. I think I met the rest of them out in the hallway there. I think, contrary to what Minister Holland said today, though, I think data and interoperability are super sexy. So, but anyway, we're here really to discuss the work of the Digital Health Interoperability Task Force, and I'm going to explain to you momentarily what that is, but I'd like to make sure that you know all of our panelists first. So, way over on the far end is Elizabeth Toller. She's the ADM. Director General Healthcare Strategies. You met her this morning. We've got Terry Price, who's a patient advocate, co-founder and executive director of Greg's Wings Project. I think everybody knows about that. We've been seeing that here for many years now at the conference. We've got Dr. Rashad Bayat, who I work closely with at Canada Health Infoway. He's the senior clinical leader. Dr. Michael Anderson, who's the interim executive medical officer in Intercity Health Associates. And Dr. Kathleen Ross, family physician, Royal Columbian Hospital, and the most recent former president of the Canadian Medical Association. So we've got an A-list set of panelists for today. So before I get any further, I better tell you what the Digital Health Interoperability Task Force is. Excuse me, Butterfingers. It's a partnership of three leading national physician organizations, right? The Canadian Medical Association, the Canadian College of Family Physicians, the Royal College of Physicians and Surgeons, which are the specialists, along with Canada Health Infoway. And the goal of this task force was really to provide a physician perspective on how to accelerate interoperability in Canada, and really to come up with recommendations that can ensure that frontline physicians, the ones at the coalface, are really able to participate in this world effectively. This task force was formed because although there's a lot of reports out there, a lot of national reports, we haven't really heard a strong voice from the doctors yet in any of those reports. So it's really our turn, time to hear from the doctors. This group spent nearly a year having meetings and coming up with their ideas and recommendations, refining those. And can I have a drum roll, please? Is there a drum roll? Thank you. Guess what? Today, we're releasing the report. And if you want to have a look at it, there's the QR code. If you can't capture this code, it's on InfoWay's homepage. We're very excited to be coming to this conference and using this as a vehicle to launch this. I hope you tell all your friends. I really want to give a shout out to the people that participated. And these are the 17 task force members here. They're mostly physicians. There was a medical student and a nurse participating as well. It was co-chaired by a family physician and a specialist. 3 of the task force members are here. So the ones closest to me are the 3 task force members. And that includes the co-chair, Dr. Byatt. Okay, he's very modest. So I had the great privilege of sitting back and just watching all the fun unfold. And I'm the messenger here today. So I'm going to try to reflect back what I heard and just give you a bit of a warning. The physician's world is not all unicorns and rainbows today in Canada. Okay, it's kind of a challenging environment, and we heard a lot of that, and I think you'll hear more of that today. But this group was great. They didn't hold back. They had strong opinions, a lot of experience, a lot of great discussions. And I really want to thank these 17 people who were not shy in expressing those opinions. So what I'm going to do in the few minutes I have is really kick off the session with a quick tour of the biggest themes that came up through this panel, and then take a look at the Task Force 5 recommendations that they published. And then when I'm done, we're going to talk to this august panel and drill down on some of those issues. Okay, so let's get started. Number 1, the group was passionate about improving interoperability. No question about that. The main reason for that is, of course, patient care, of course. In a modern health system, health providers need to access all of the relevant information about their patients to provide the best care. If they can't find important information when it's needed, guess what? Errors can happen, and sadly, errors do, and they are occurring right now. As a result of limited interoperability, you just heard Waldo. What was the number there, Waldo? 80 minutes? That's what we heard. Physicians can spend literally hours every single day looking for information, sifting through mounds of information, otherwise trying to work around very broken processes. It's frustrating, it wastes their time, and it's a huge contributor to the overwhelming administrative burden that is currently hobbling those providers. Patients have the same challenges. If you've ever tried to find or collect your data from multiple sources, you know how frustrating that can be as well. And finally, we have incredible data across our healthcare system, but we can't really aggregate it because of privacy issues, because of interoperability issues, lost opportunities for public health surveillance, health system management, prevention programs, support for marginalized populations. And of course, this data could be incredibly valuable for research and innovation in AI. So, no shortage of enthusiasm for advancing interoperability. It gets a check mark. So there you go. The task force also heard from several national groups and is very supportive of the efforts that's underway. And I'm not going to repeat them all because you heard them all from Joe today, this morning, but lots of work on data standards, an interoperability roadmap, important work to establish indigenous data sovereignty, ensuring that First Nations, Inuit, Métis people gain control over how their data is used. Project HALO, so we can integrate community providers and their electronic medical records. And probably the biggest impact, I think, is probably Bill C-72, if we can get that through, as you heard from Joe this morning. So you get a check mark too, okay? That's a positive that the panel highlighted. The the group felt pretty strongly that current privacy legislation is not fit for the modern digital age. It's a patchwork of laws across the country, many of which have not been updated to reflect what we can now do with technology. In the clinical setting, it's confusing. We lack clear guidance for many common situations, often leads to more cautious behavior from providers and organizations. In other words, our current legislation actually impedes appropriate data sharing rather than enabling it. There's no check mark for you. Task Force also recognized the great work being undertaken at the national level and the huge efforts underway in provinces and territories to advance digital health solutions. But this may not be enough. Although we tend to think of interoperability as a technical issue, the real challenge, as we've heard many times today, is simply having multiple players collaborate and how they're going to do it together. Interoperability is a team sport. So to achieve broader interoperability in Canada, the task force believes we need to amp up our collaboration level, starting with more effective collaborative governance and more explicit commitments from our federal, provincial, and territorial governments. The task force noted quite wryly the absence of a rigorous plan with clear deliverables, partner commitments, budgets, and date. Okay, have you heard any dates today? Do you know when things are going to happen in Canada? Because I didn't hear any yet. We still have a couple hours, though, in the day. Maybe we'll hear some deadline dates. But I think that was pretty clearly pointed out by our panel. And without clear collaboration and commitments, the task force is concerned that that delivery date, where there's real improvements that you can feel at the front lines of care, may be far off in the future. No check mark there either. And finally, and this is the big one for the task force, they believe there's a fundamental disconnect between many of the approaches taken by organizations and governments to address interoperability and the perspective of Canadian clinicians. Frontline clinicians are the last mile of interoperability, and if we can't enable them to participate effectively, we risk undermining the entire enterprise. And yet it seems that no other national interoperability reports have thought this through carefully. So the panel spent quite a bit of energy on this. And there were some big questions. You know, how can we address the need for providers to collect, standardize, and curate their data? How can we optimize current provider workflows that are a badly broken hodgepodge of poorly integrated digital solutions and paper processes? And how can we prevent interoperability initiatives from increasing provider burden rather than reducing it? With so many Canadians who just simply don't have a doctor, and with provider burnout already a serious concern, any more additional administrative burden is going to limit their capacity to care for patients and further strain the workforce. And this is what they said: unless this is addressed, the task force is concerned interoperability initiatives will place additional burdens on clinicians and could lead to the failure of well-intentioned efforts to support connected care. Okay, so those are the themes. I don't know if anybody's surprised by those, but let's just jump into the recommendations now. There were 5 of them, as I said. I hope you'll all have a look at the report, maybe put these under your pillow, but I'll summarize them quickly. So recommendation 1 is really about increasing collaboration and commitment. The task force said federal, provincial, and territorial governments should commit to co-developing and fast-tracking a comprehensive plan that will deliver tangible improvement in interoperability at the front lines of care within 5 years. The collaborative effort should be overseen through the immediate establishment of a National Health Data Governance Council. The council must be empowered by FPT governments to drive accountability timelines and cross-jurisdictional commitments, ensuring provinces and territories adhere to a minimum unified framework. As Minister Holland said this morning, we need radical collaboration, and I think this is a place to start that process. Second recommendation was really around aggressively accelerating the existing policy and legislation work that's underway. In other words, keep going, just faster. We need to pass Bill C-72 or something equivalent, get the buy-in of provinces and territories, and get started on implementing regulations. We need a national data stewardship framework with updated privacy legislation. And we need to ensure Indigenous participation at the table and inclusion of Indigenous data sovereignty policy or legislation. Number 3, provincial and territorial governments should meaningfully include frontline clinicians in deploying health data solutions that involve them. The task force spent most of the time on this recommendation because, as I've said, this element has not received the same level of national attention. This is really addressed primarily to provinces and territories who are best positioned to address these barriers. And the solution to this problem really involves ensuring that health data solutions are co-designed with practicing clinicians, including their input in a meaningful way at every stage of the design, selection, procurement, testing, implementation, and ensuring the solutions meet the needs of clinicians and improve patient care and navigation. The task force would also like to see every province and territory develop a strategy and a roadmap that will optimize clinical workflows and produce measurable reduction in administrative burden, down from 80 minutes a day to something quite a bit lower. The task force was very blunt. Ensure that the administrative burden and cost of interoperability initiatives are not downloaded to clinicians. Recommendation 4 is have organized medicine play a role in guiding and supporting physicians on data stewardship and interoperability. The task force looks to their medical associations and related organizations to continue to develop guidelines that help providers deal confidently with privacy risk and manage the tsunami of data that comes their way. The task force also expects their provincial or territorial medical associations to support the advancement of interoperability regionally and to advocate for greater clinician leadership in digital initiatives. And finally, there's still remains some very significant practical barriers to interoperability at the front lines of care that make it very challenging for providers to participate. Although most of our technology is fabulous, we still haven't solved that last mile problem very well. The task force would like to see Canada's research and development funding organizations help to solve this issue by stepping up and committing to funding innovation that can overcome those barriers. Examples include innovation to help address the current inadequacy of many electronic medical records for healthcare teams, or AI solutions that can take the drudgery work out of capturing, standardizing, and sharing data. AI is already enabling real change, and there's great opportunity to steer development efforts toward enabling clinicians to participate more effectively. Okay, so that's the report. I think we have a slide here. Okay, I'm going to leave that up if you want to download the report. There's the QR code right there. And I think we'll jump into our panel. You guys ready? Okay, and there will be a chance for the audience to ask some questions as well. So I'm actually going to kick off the panel by calling out what I think is the elephant in the room. We all know that prioritizing interoperability is crucial for the safety of patients and for the sanity of healthcare providers, but whose job is it to deliver it? I think, Rashad, you wanted to go first on that one?
Sure. Thanks, Ed, and I hope everyone can hear me. Thanks and welcome. So I think, Ed, everyone really has a role to play in delivering interoperability. So vendors, provincial and territorial governments, patients, patient advocacy groups, clinicians. We can all contribute from an advocacy perspective or a technical implementation perspective, an adoption implementation perspective. Having said that, as you astutely noted, the first recommendation of the task force is that the responsibility be shared, albeit with clear accountabilities. So the federal, provincial, and territorial governments must work together on that shared plan that we discussed, one that outlines distinct timelines and commitments to advance interoperable solutions within a fixed 5-year time frame. The rubber will really hit the road, however, at the provincial and territorial level. Physicians, nurses, and other clinicians, we will look to our national organizations for guidance, but we will also, first and foremost, many times look to our local initiatives and our local medical associations for guidance. We will seek support from local, provincial, territorial resources. And then there's also that level of responsibility that we have, that physicians and other clinicians have, if presented with reasonable change supports and reasonable interoperable tools that enhance our abilities to care for patients rather than adding to our administrative burden, and provide an opportunity for us to have less time in front of screens. If all those conditions are met, then it is also our responsibility to do the best we can to use those tools. So if all these groups can be engaged with provincial and territorial approaches, which in turn then align with a coordinated pan-Canadian plan, I think we can make some headway.
Anybody else want to add to that?
Just to say, I completely agree with you that it's a team sport, right? And that nobody alone is going to fix this problem. And as the minister kind of called out, we need that radical collaboration to happen. So from a federal perspective, I mean, we do everything in our power to play that convening role in bringing together federal, provincial, and territorial governments and Indigenous partners. We also have to bring vendors along. We have to bring the physician community along, and patient partners and citizens. So we can create the collaborative frameworks, we can bring people together, we can provide funding, support CIHI and InfoAid to facilitate that pan-Canadian collaboration, provide legislation to try and accelerate those goals. But I think at the end of the day, everybody has to come together towards that common direction and that sort of collective action to be able to see real change happen.
Great.
I might add to that if I can. And I think this is one of my fears, and Rashad, you touched on that in a world where it's everybody's responsibility, it's nobody's responsibility. So as we say, yes, everybody's got a role and everybody should come together, we actually need to be very clear about who's responsible for what and in what timeline. Average changes in healthcare take up to 17 years. I'm probably going to be dead by then. I'd like to see this happen before then.
Yeah, thank you. Yeah, that's a great point. I mean, I think the challenge is we have 13 healthcare systems. So how do we make that work? How do we get those sort of commitments? So I don't know if we're going to answer that, but I think it's up to you and the audience to help us figure that one out and get some dates around this. So Elizabeth, I'm going to pick on you again. And you kind of started to answer this. You're the only government employee on our panel, so I'm going to pick on you. So this report was created mostly by a bunch of physicians. And I think all of us are very curious to know how those recommendations align with what at least Health Canada's thinking, where you think we might have got it right, and where we're totally off base and you'd like to object.
I mean, I was really pleased to see that all the recommendations seem to really align with the majority of our national initiatives. Strong call out to Bill C-72 and the roadmap, which is sort of the main vehicle that's driving the interoperability work for standards, both on the data side and on the technical side. Really pleased to see the strong call out to stewardship, that sort of collective responsibility we have to shift the culture in not just holding the data, but in effectively stewarding it and keeping patients at the center along the way. And a clear role that we've defined for CIHI in terms of playing that leadership role and creating the governance necessary to be able to provide the consistent guidance, especially for, as you have noted, the challenges still being faced with the alignment of privacy legislation and the interpretation of privacy legislation, which tends to be one of the significant challenges. Also really happy to see sort of emphasis on AI and the importance of using those tools to support administrative burden, but also making sure that there are safeguards in place, which is very much aligned with the work that we've been doing with our federal, provincial, territorial colleagues. I think the key message for me, having read this report, is that in our kind of collective plans, we perhaps need to put a greater spotlight on change management and the role that we can all play in supporting the physician community, who, as you said, are the the last and most important leg in terms of our journey that we are on to achieve interoperability. And I think we can reflect a bit more on how to better incorporate the physician and health professional perspective in our governance. And so, I think we'll take your recommendations into account in terms of your thoughts on a council. I do believe we have very strong governance in place, but there's an opportunity to improve it and make sure that the physician voice is very loud and clear within it.
Anybody else want to add to that? Dr. Ross?
I always want to add something. And thank you for that. I really appreciate it. When we looked through the task force and the recommendations, I walked away with 4 main things that are our asks for this community as we look forward to accelerating adopting interoperability standards. The first is to actually invite us. As clinicians, we want to actually be there when we're talking about things that are going to change how our workflow goes day to day. But don't just invite us, actually hear us. Listen to what the challenges are. You mentioned the 86 minutes spent looking for information. I still do obstetrics. On my last 24-hour call shift last week, because I knew I was coming, I tracked my time, and it was 2.5 hours of that 24-hour shift that I spent logging on and off various portals to get the information that I needed to treat the patient that was sitting right in front of me at the time. Also on that same shift, every single time I wrote a clinical note in our new electronic health record, a copy of that clinical note went to my community office for me to go and read again at some point in the future. Yes, we need to be interoperable, but we actually need to be smart about how we are interoperable. You need to provide us time to train us, get us to understand what is the process, what do we need? And then finally, and at the end of all of that, once we start to get things in place, support us. I've been an early adopter of a lot of tech in my day, and the cost of implementing that tech in the community is always downloaded onto me as a clinician, and we simply cannot afford to do that anymore, and I think we're really not interested in doing that anymore.
And I might add that it might be heresy in this group, but the notion that interoperability should involve every single bit of data being dumped to people is actually problematic. So that exacerbates the problem we see in healthcare, where we have so much noise that the challenge is finding signal in the noise. So interoperability has the risk of making that signal to noise phenomena worse if we're not intentional. I want sharing of meaningful information, but just massive dumps of data actually, I think, increase clinician burnout, clinician workload in a non-valuable way. So I think interoperability has a little caveat to it, which is we want thoughtful, meaningful interoperability.
Sure. That was interesting on the panel to hear people talk about the fact they don't want data, they want information. They want summaries. They want a report that kind of brings everything together. And I think AI is actually a great opportunity to do that in the future. But I'd like to pick on you, Terry, a little bit, because I haven't yet. I guess you represent the patient, which is the other 40 million of us in Canada, on this panel at least. So I'm just curious, if we go back to our questions here, we heard from Elizabeth about how the federal government sees this. We heard about Dr. Ross about some of the stuff closer to home. How do you think this can happen, and whose job do you think it is, and what's the role of the patient in making this happen?
Yeah, well, thank you for the question and for the opportunity to be on the panel as well. And I've learned a lot from everybody on the stage, and I'm always grateful for the opportunity to have these discussions and learn more from different perspectives around some of the issues, because from a patient perspective, and I think in the past we made a lot of assumptions about how the health information works in healthcare, sort of assuming that it works in healthcare. And I think as over the years, we've learned a lot about how challenging and damaging the lack of information flow can be for patients and families. We tend to focus a lot of our conversations around the change that we want to see in healthcare towards that teamwork, like seeing strong teamwork in healthcare. And we fully believe that you can't have effective teamwork without access to information. And we talk about teamwork from the patient's care team perspective when you're seeking care or part of a patient's care team. We also talk and emphasize, and I think it's been obvious today in the conference overall, and also in the first couple comments on the panel, that the collaboration at a system level, we need that as well. It would be wonderful if there was sort of a silver bullet that we could just say, or hold, there would be one clear place that is accountable for all of this work, and they just need to figure it out, and then it'll solve all the problems for everybody. But the reality is that healthcare is very complex. It's not going to be a single group or single organization or profession that's going to figure this out. We do need to be working together. And just like Kathleen said, that physicians want to be heard. I think patients and families and members of the public as well want to be heard, and even have the opportunity to gain a better understanding of what the current reality is and what the potential for the future can be, so that we can help support the steps that'll make a difference in the future. Because I think a lot of people learn about the reality of the healthcare system as they're interacting with it. And that's not necessarily the best time to be learning how critically important it is to gather your own information, or to learn that when you're interacting with the emergency room, they can't necessarily see all of the information they need, or really any interaction. There may be gaps in your information. In those moments, it's very challenging and stressful to be trying to fill all those gaps from a patient-family perspective. But if we can have these conversations in the not when you're trying to seek care, and really help support the kinds of changes in the healthcare system that'll make a difference, I think there's lots of people that want to be able to support that. But we need to have those transparent conversations, and I think that's why we're optimistic about the number of reports lately that are touching on this, some of the work that's being done by a number of different organizations. It is more opportunity to have these discussions and shed some light on the current reality, but also sort of try and build some optimism and momentum towards a better future.
Yeah. Great answers, everybody. I don't know if I'm supposed to insert my own bias because I'm supposed to be moderating. But I've been in the healthcare system a very long time, and I've seen lots of efforts by governments to get providers and other organizations to collaborate. I actually call it the love-based system, right? Because there isn't really a business model. We're not really paying folks. So I love collaboration, but I'd much rather see contracts and joint ventures and deals and commitments. And I think that's kind of what the panel is saying. We want to see it on paper. We want to see a date. We want to see everybody say, yes, we are committed to doing this, so that we can turn the radical collaboration into radical activity as well. The task force also spoke a lot about what we call the human factors of interoperability. I wonder if the panel could explain what that is and tell us why that's important to patients and providers. And I know, Dr. Anderson, you wanted to take this on.
Sure. Too often we talk about interoperability only in a technical sense, and we thought it was really important to lean into and highlight the human factors around interoperability. So that talks about system level, that talks about relationships. If I was looking at the domains of human factor interoperability, I'd talk about things like governance and policy, education, culture. One of the things years ago I used to hear when I first got involved in quality improvement work was the notion that the front line in healthcare is where good ideas go to die. And sadly, there's an element of truth sort of hidden in that, which is we have great thought leadership, we have great recommendations, and we often do a poor job of the change management, considering the humans involved, the workflow, what our day really looks like. So I actually think, in fairness, that adage puts too much of the emphasis on healthcare workers being an impediment. And the truth is, what we rarely see, unfortunately, is good co-design. So interoperability, we've talked about it being a collaborative sport, a team sport. We need to co-design effectively, and that means not involving frontline clinicians at the last minute when it's baked and made and, oh, here it is. We need that to happen upstream. And I think that the human factor piece of interoperability is as or more critical as the technological aspects.
Yeah, I would just really support that, and the people aspect of actually being able to enable any of these changes. I mean, it'd be great, again, if you just deploy a technology and it solves all the problems. It's the reality is that's not going to be true. But I think there is that we do need to create the conditions for people to be able to do their best work. And I think that legislation change is part of that, that well-designed tools is part of that, and potentially changing the way we approach change in healthcare is part of that, that we really do need to be creating those conditions that enable people to understand different perspectives in the healthcare system, and to have a deeper knowledge and collective knowledge and intelligence around what the issues actually are, so that we can unleash some of the problem solving and innovation that can happen in the system if we do have that better shared understanding and that approach that really is focusing on how the interactions between people, the human factor, how that is embedded all the way through healthcare. Like, you really, that will always be true in healthcare. It's a human and teamwork focused sector.
I just really agree with that. I mean, I think we're making a lot of progress in removing those technical barriers, but the people and processes part, I think, is probably one of the most important things. And I think we need to empower clinicians who have for years been custodians of data for an analog age, and empower them to be effective stewards, along with the patients that they serve, who also, I think, play a role in being stewards of their own data as well. And part of that, I mean, you mentioned legislation and, the standards to try and deal with the technical side. There's, the co-design, which I think is very important. And then there's the policy coherence piece, which I mentioned earlier, I think is what we're really hoping to see CIHI, with the support of InfoWay and many other key stakeholders involved, play a role in terms of providing that guidance in terms of who is responsible to do what, how, what are the rules of the road, how do we effectively collect data once, share it with trusted partners, and let it be used many times across the health system in the public's interest.
I would love to add to that too, because I agree with you completely. We have to make sure that we are setting that North Star. Where are we headed, and what's standing in the way? And what stands in the way always are 2 4-letter words and 1 5-letter word. And that's time, tech, and of course, money. And actually, after today's discussion, I would add a second 5-letter word, and that's trust. So we need to ensure that everybody's got an idea where we're headed, that we're all rowing in the same direction. And I agree completely with the comment earlier that there were a few positive things that came out of COVID. And one was that we had the ability to make our healthcare system truly nimble when we aligned behind common goals. And I think this is the first step in showing that there's alignment, in bringing everybody together and starting to understand what has to happen, and then clearly naming who needs to make that happen and in what timeline.
Great. Yeah, I was a little worried when you started talking about 4-letter words there, Dr. Ross, but you brought it back. I just want to drill a little deeper into this, because I think this is the crux of the work that the task force did. We've heard very clearly interoperability just ain't going to work if clinicians in the community can't use it. We've heard that very clearly. So the panel did debate a lot of strategies. We've heard sort of part of it now, but I'm wondering what everybody took away from that conversation. So what strategies do you think could actually be implemented? What are the action items that we can take out there that are actually going to make this change happen? And what's going to make that happen without creating additional administrative burden?
Yeah, I might build on, I'll go to a 5-letter word just to keep it above board here. I think Dr. Ross's comment about trust is important. I think if you took healthcare, if you took clinicians of my generation and asked us how we felt our trust in what EMRs were sold to us as being capable of doing and what they've delivered on, there's a gap there. Trust, I think, trust is a time phenomena. It takes time. I think we need to pick and strategically pick some easy wins to start gaining momentum of trust. So I do think trust is a key element in making this actually actionable.
Yeah, I think there's a lot that you can unpack in that for sure, but having a clear understanding of where we're headed and what we need to do to get there. I mean, I too bought into the EMR is going to solve all of our administrative burden mantra, and in fact, publicized something to that effect that I'm going to hell for. But I think at the end of the day, we need to understand. Now, we deal with these big behemoths of healthcare systems that are built on legacy systems that are developed, and every small organization developed its own digital solution to meet its own digital needs. They were never designed to talk to one another. My chart notes were never designed to gather meaningful data. They were designed to tell future me what I did today, so that when I saw the patient the next time, I knew where I was going. And we have to reframe all of that. But at the same time, we need to make it so that I don't have to spend additional time at the end of the day coalescing, uploading information. One of the task force members actually shared a picture of their LinkedIn job offering. And he's a family physician and an emergency room physician, and there were 2 offerings of data entry clerk in his LinkedIn post ahead of his offerings for family physician. So LinkedIn has figured out that's where our problem is, and I think that we need to accelerate fairly quickly. And I like the idea of layering in AI and getting AI to do some of the work for us, but we need to have some pretty clear regulatory and privacy legislation guidance if we're going to start using these tools, so that there's some degree of protection for those of us that are sharing our data as patients, and those of us that are actually trying to steward it. We need to know that, who's responsible if there's a breach and harms arise from that.
I might share a story a little. At one of my organizations a couple of weeks ago, one of the data people who was trying to extract information in a fashion that made some sense for reports said to the clinical team, what do we have to do to get you to chart differently? You never fill in the discrete domains, everything's in your unstructured notes. This is useless to me. I want your teams to change how they document. So my clinical leads used words like revolt, revolution, outrage. The technical team was trying to change the workflow to suit their needs. And I think that's a conversation that will be incredibly important in this work, because what they were saying was, I want you to structure your world, your clinical everyday workflow around my technical needs. And it was very good that they heard the words out of the clinical leads.
Yeah, that's strong. We take that one step further, actually. So I know we gave, Health Canada gave us instructions today about great ideas. But a lot of what you're describing comes down to provincial, territorial, or, hospital sort of management decisions. We have some the leaders of provinces out in the audience here, unless they ran away from this session. What should they do? What should the provinces, the leaders of, the CIOs of a province, what should they go home and do to support physicians and make sure that we can participate in this interoperable world?
I could, Ed, maybe I'll throw in a comment on that one, and maybe it's building a bit on what Dr. Anderson said, trying to avoid the tail wagging the dog situation. I think co-design is critical, and I think the provinces and the territories can really help to influence more co-design baked into how we roll out different types of interoperability-focused initiatives. So engage clinicians and, physicians and other clinicians early and at every step of the implementation. It should, that way you can ensure that a digital process, whatever it is well thought out, solves an actual problem or meets an actual need, has a great user interface and a great user experience, and also saves clinician users time that can be redirected to patient care. So I think we can use new and emerging living labs to test out some of these new tools. And I know there's a few folks in the audience who may be involved in initiatives like that, so I'd love to see some of those ideas continue to gain momentum in the provinces and territories.
I know each province and territory is at a very different journey and stage of maturity, and so it's hard sometimes to achieve that full alignment. But I am encouraged and hope to see more of sort of galvanizing around common priorities and use cases that can be used to unpack all of these challenges. And I think the IPS is a great example. We saw some great presentations this morning from our provincial counterparts. You know, and I think Abby mentioned it's not a silver bullet, but it's a great way for us to unpack the foundation necessary and looking at it not just from the technical side, but from the stewardship side and from the change management side. And I think AI and the easier AI tools, again, not a silver bullet, but you know, AI Scribe, seeing lots of energy and focus on that as a key tool for saving time and administrative burden for physicians. So let's galvanize around that and figure out what do we need to do to accelerate its adoption, its, you know, effective procurement and deployment, and all the sort of safeguards and privacy and all those things, and use those to kind of then spread and scale even further.
Yeah, great.
So, yeah, for sure. My advice would be actually twofold. Number one is accelerate the patient access to their own data. That has to be a priority, and because it's a provincial system, I think you count 14 if you count the military, actually. But I think that we have to accelerate patients having access to their own information out of the gate. And there's lots of different solutions, lots of different ways to approach it, and I think that we make that number one. Number two, and we didn't touch on it to date, is that we really do need to accelerate access to primary care across the country. Interoperability is wonderful, and we heard an example today where the patient was going to have all of their own information that they could port around from place to place to place to get access. We would never in a million years say in our education system, we're going to give the kids all the books and we're going to give them all the teaching plans, and then we're just going to expect them to teach themselves. And yet this is the system that we're building now, even with having patient access and interoperability as a forefront. Unless you have the foundational backbone of our healthcare system, it's not going to solve the problems we see in Canada today.
Yeah. I might add one more, which is my advice would be it's not about what the end state looks like, it's the how do you get from here to there. And the here to there is a long road. And this sounds politically incorrect, but when you have complex things, it's not a bad idea to map out the what's in it for me at different points. And I suspect the exercise of building trust and momentum in this space is finding a few things where the what's in it for me aligns between different entities. When there's, even if they're not exactly the same what's in it for me, when there's an attention to there's something in it for me around a pain point, I think you have a little bit more impetus to actually innovate and drive change. So being a bit attentive to the what's in it for me.
Yeah, that's great advice for provinces all around. Thank you. I'm going to ask one more question, and then I'm going to open it up to the audience. So this gives you time to think of your question and wander up to a microphone if you have one. So my last question, of course, no panel is complete without this question. You know, even though we're looking to modernize our health data stewardship and our privacy legislation, and we heard about Kai-Hi's efforts to start a governance framework for health data stewardship. How can we really ensure the right balance between protecting sensitive information and making it accessible to patients, to care teams, and making sure that we have the trust of the public?
I can start, and I think it is the need for that conversation that is a bit more balanced than maybe it has been historically, that there has been a significant emphasis on the need for privacy and security without necessarily the acknowledgement of how putting information into silos and not having it follow the patient through the system also causes harm, and how incredibly important it is to be able to share information and have information available at the fingertips of a patient's care team. And I want to emphasize that patients are members of their care team, and that their family members or caregivers and loved ones that they want to include are also members of their care team. And so they should have access to the information that they need to be able to make decisions as well. And that is incredibly important. And we believe it's a critical patient safety issue. And that without having access to the information that you need, we know that harm happens in healthcare because of that. And so it's not, I'm in no way intending to dismiss the importance of privacy and security, but I think it's a yes and. We need both, and we need to have that more open, balanced conversation about how critically important it is and what the current reality is versus where we want to go in enabling the teamwork and safe care and creating the conditions for safe care.
I may take it in a little different direction. I have a personal and professional interest in Indigenous peoples' data governance. And one of the things we talk about a lot in healthcare is about personal health information governance, which we have rules and protocols around. And we almost never talk about collective data governance. So that's what in the Indigenous data space, we talk about OCAP principles: ownership, control, access, possession. And part of why that's important is collective data has tremendous power to do good things and to do harmful things. So once we start into the space of more interoperability, I think maintaining data provenance, where did data come from initially? What is its history? Becomes increasingly important. I think that becomes important as we venture into AI spaces. What inferences are we generating? So we have a lot of governance around individual data, and this will force us into the space of thinking about what does collective data look like and what rules and governance should be in place around collective data.
That really goes to the trust factor again, right? So there's a lot of conversation about implicit consent. So when patients come into a healthcare facility in an area that has shared data, so a shared patient summary, I hear this quite a lot. How much of my information in my chart is going to make it into data that's shared with government, with public health, with other areas? And I know in the Indigenous communities, I've heard the same concern. How much of this information needs to be shared to make the system work so that things don't fall through the crack, but I don't want to necessarily share everything with this other entity that I don't trust.
The flip side of that is if we don't do it well, our fear is that we'll be ghosted from collective data, in which case we're erased in the same way as we don't want false or misinterpretations to occur. We don't want to be absent from the data either.
Great. Any other privacy comments? No? Okay, so we'll open it up to the audience. If you have a question, please wander up to a microphone. I see Dr. Alarakia, you're first up.
Hey, great. Thanks very much, and great panel and great recommendations. Looking forward to diving to them more. Lots of discussion about co-design, and co-design needs to happen with clinicians who are right now busy, overwhelmed, and are the ones that we need to engage and try to understand and empathize with. How are you going to engage those clinicians who are on the front lines who may not have time to engage? What strategies should we take to actually get them involved? Because I think it's a great idea, but it's hard to put into practice. So I think in the spirit of getting things done and having timelines, how do you engage those clinicians who are hard to engage?
I mean, I think it's back to, it sounds like the dirty word, but the what's in it for me. Clinicians, I think, will get involved in things that they're interested in, that they see value, that they... one of the challenges, we get often involved in too many things where our impact is negligible. So I think if you will find clinicians will invest in projects, in things that they feel highly invested in. I don't actually have trouble getting clinicians to invest in this type of work if they see it as valuable, if they see it linked to something that resonates in their world. It does get a little bit challenging when you get at too high a level and people go sort of, well, how does this relate to what I see every day?
I think they should come and follow me around at 2 o'clock in the morning when I'm on call to really understand where the barriers are. Once every other office is closed, I can't just phone and get a test result and have to go try and find it myself. But tying these engagement opportunities to specific problems that make everybody in my profession have hair my color. Those are really, really important things, because we're looking at targeted problem solutions. being able to name the problem and share what we see as potential solutions is incredibly empowering, and we will engage. To just show up and have a complaint session, unfortunately, leads to nothing. But if we have an opportunity to say, these are the pieces that I need to fall into place in order to make my workflow faster, better, more productive. And I think these are things that we need to actually focus in on. And as long as clinicians see that their voice is being heard, that their problems are being solved in a collaborative way, they're going to engage and continue to engage. But not everybody's going to engage at the same time. We have lots of passionate physicians who get involved, and they get involved for a few years. They get burned to a crisp because they're frustrated, and then we just bring more physicians on board. But we need to make it okay that you can come, add your voice in whatever way makes sense to you, and then move along, and we'll get somebody else to lean in.
Yeah, there might even be value just in saying you're going to have a couple of physicians come to the event, because I don't know if people that deliver solutions always sit in the primary care doctor's or specialist chair and think about how that influences their work, right? We tend to deliver products and then try to train the physician on how to use them instead of thinking about how does that fit into the physician's general life and workflow. So I think the idea itself is very important, even if you only get a couple of them. I think there's, who's next? Oh, they're very polite. It's very Canadian. Miriam, you're next, I guess?
Yes.
Yeah, okay.
So I think we have heard this morning from Alberta, BC, Ontario, NB, Nova Scotia, the work that they are already doing regarding interoperability through the patient summary, as Elizabeth mentioned. So my question associated to the task force report is, how are you evaluating also the contribution of the work that is already happening within patient summary and its usefulness in the physician perspective? That's my question. And if there's value, there's also an approach towards evaluating or assessing the benefits of this into the recommendations that you have stated already. So back to the monitoring of the task force recommendation that you mentioned, which is how are we going to monitor what is happening and when, and its usefulness or its impact. So sorry, it's a long question, but you get the gist.
So I think it's a really important question, because one of the things that we're trying to avoid with interoperability is the harms that come to patients. It's not just about how much time I spend finding stuff, although it's a really interesting anecdote. It's about the harms avoided. So when you put up a stop sign for traffic and you avoid pedestrians being hit at that corner, we don't track how many pedestrians didn't get hit at the corner. So how do we actually then land on metrics to know that this is making a difference? I would say that it's the number of tests that get duplicated. It's a number of minutes that patients have to spend sharing their history again and again. It's how many times that we need to go sign on and off various platforms. There are ways that we can track it, but the biggest harm we're trying to avoid is harm to patients for missed information, and we're not gonna capture that.
I think the international patient summary is a bit of to me, it's a bit of a metaphor in the sense that it's not the Holy Grail, but the work that you have to do to be able to generate an IPS is actually the work that you have to do to be able to make things interoperable. So it's almost like it's not that it in and of itself is such a special thing, but by the time you've got to the point where you can generate one, you've done the work involved to set the foundation for interoperability.
And empowered the patients in the process.
Yeah. And I'll just maybe add a quick note to that to answer Miriam's question, which is a really good question. In terms of tracking, the impact of something like the patient summary, some of the questions in the physician survey that we did in collaboration with the CMA, and that has, the physician survey does have a series of questions that do align with an area of interoperability, receiving and sharing information that could be impacted by something like the patient summary. And so we may actually see, when we revisit a physician survey in the future, we may see a change after these patient summary initiatives have had a chance to take flight and really permeate the various provinces and territories and spread across the country. So hope that helps to answer the question.
And just to add, I know you're getting everybody to answer this, but while not a direct measure of IPS, to your point, I think this will contribute to a greater number of individuals being able to access their data and clinicians being able to share data with other clinicians involved in a circle of care. And those are the two main metrics that are being measured across the country as part of the Working Together to Improve Healthcare for Canadians plan. So CIHI is working with the provinces and territories to collect consistent data about that. So I'm feeling hopeful that we'll see some progress on that as a result of all the great work that the provinces and territories are doing.
Perfect. I think we have time for one last quick question. I think that's you. You get the last word.
Yes, thank you. I hope my question is quick. So a lot of data and modeling that's there existing in Canada shows that we'll be north of 20% for older adults over 65. And the community support services and home care have described a data cliff when coming out of primary care and acute care. So my question is a two-parter to the physicians who are part of this report. Did you take that into consideration? Because that will also add to physician burden with a binder coming with a caregiver to speak about these things. And from a Health Canada perspective, what investments are we making into the home community care and community support services to ensure that the entire circle of care, not just the acute and primary care, are covered?
Can anybody solve that?
Other than to say yes, you're bang on. It is definitely a chasm of information that happens in the home, and there's been lots of attempts to try and capture that, hopefully in a curated form. So one of the values I see with the patient summary is to be able to have all members of the care team, including caregivers and patients themselves, being able to add to that patient summary things that are of acute interest.
I work in both an acute care and a community setting, and in the community setting we find it takes 42 days on average to get information from when a person's discharged from an acute care setting. So that's 41 days the person's being cared for in the community, flying relatively blind right now. And repeated studies show that both clinicians, administrators and patients and families understand that transitions in care are risky, dangerous exercises. So we have these transitions in care to the community where you are unarmed, you're just flying without information. Everyone seems to see that it's a risky venture. We have to cross that early. I think that's one of the early wins if we're careful.
I'll trade you those 42 days for a copy of every single chart note that gets written in the hospital.
So, there's a phrase or it's a quote from a science fiction author that the future is already here, it's just not evenly distributed. And a lot of the technology already exists to help give patients and care providers and care teams that come into the home access to that information. It's just not presented in a way that is user-friendly, easily accessible. I see patients, some of my patients in their homes, and one of the key pieces of information that would be super useful right across the board, the patient, their caregivers, the entire care team, is a discharge summary, something very simple that just outlines the plan when you come out of the hospital and is a bit of a handoff, that baton that we talk about. And so the ability to do that is there at the moment. And so, some of the ways we can do it is by, as Kathleen mentioned just a little bit earlier, is accelerating that patient access to your record so you can have those pieces of information, even if it's not you necessarily who's going to be interpreting it as a patient. You may have a colleague, a caregiver, a family member, somebody helping you out. So there are ways to address this, and I think the provinces and the territories can work on that as time goes on too.
Okay, well I think that's a good finish to this panel. You mentioned science fiction. I think it's all of our job to take this science fiction and turn it into reality. And I don't think you've heard the last from this panel, because I think these are recommendations worth us not forgetting and following up on. Thank you. This has been a really, really great panel. I've enjoyed it. I hope you did, and thank you all for your attention.